Hello everyone, welcome back to One Touch Pharmacology. Today we are going to discuss a very important topic, antibiotic or antimicrobial resistance, the ticking time bomb. In the early 1900s, when there was no antibacterials or no cure for infectious disease, human suffering was enormous. Infectious diseases were the leading cause of mortality. Almost 90% of the children who contracted meningitis died due to it, and those who survived were left with some lifelong disability. It is believed in World War I, more soldiers died due to wound infections than due to the bullets. This period was rightly called the Dark Ages. In 1928, Sir Alexander Fleming came up with this molecule, penicillin. Since penicillin was commercialized, it has saved millions of lives. In World War II, it had saved the lives of many soldiers from wound infection and pneumonia. And this drug was hailed as the magic bullet or the miracle drug. Following the discovery of penicillin, a lot of new antibacterials came into the market. And this was the end of Dark Ages. And this discovery of antibacterials ushered in the golden era of modern medicine. During his Nobel Prize acceptance speech itself, Sir Alexander Fleming had warned of drug resistance. And true to that, within 2 years after penicillin was commercialized, penicillin-resistant Staph aureus strains were isolated. Between 1940 and 1960, a lot of new antibacterials came into the market, right from tetracyclines, chloramphenicol, aminoglycosides, macrolide, glycopeptides, so on and so forth. And this is why this period is called as the golden age of antibiotics. Following 1970s, there were not many new antibacterial classes that came into the market. The drugs that came were mainly Me Too drugs with no added advantage. And after 1990s, there is a great lull in the production of antibiotics. Our antibiotics pipelines has almost dried up. Perhaps the main reason for it is for a new drug to come into the market, it takes around 15 to 20 years and millions of dollars are spent for it. But once these antibacterials come into the market, the microorganisms gain resistance to it very quickly. And there is no guarantee that the pharmaceutical industry would recover whatever money they had spent for this molecule. So because of this, the drug industry is not very interested in investing in antibacterial research. So these are some of the common resistant organisms that we are facing, right from carbapenem-resistant Enterobacteriaceae, vancomycin-resistant Staphylococcus aureus, vancomycin-resistant Enterococcus, multi-drug-resistant tuberculosis, multi-drug-resistant Salmonella. So the problem is really, difficult. The issue of antimicrobial resistance is staring right at us. Right now, we are in the middle of a global health crisis and we need to act right now. Infectious disease is the second leading cause of death. According to a report in 2019, almost 7 million people die every year due to drug-resistant bacterial infections. And it is projected that by 2050, there would be almost 10 million deaths per year due to drug-resistant infections. That means one person would die every 3 seconds. If you think the situation in India is better, it is no better, perhaps even worse. We are losing our ammunitions, that is antibacterials, against the bacteria that is continually evolving. And if we don't act now, we would be pushed back into the pre-antibiotic era or the dark ages. That means a simple cut or a simple throat infection can become a death sentence for any one of us. So what is the impact of antimicrobial resistance? Antimicrobial resistance leads on to increased mortality and morbidity, resulting in treatment failures and longer period of infectivity. Longer period of infectivity means greater spread of infections, greater spread of drug resistance. So you have to spend more money on antibiotics, which would be costly. And these costly antibiotics are the ones which are more toxic. So again, that would increase your hospital stay. Again, treatment for the adverse drug reactions, treatment failures, and this is a vicious cycle. And it is projected that by 2030, antimicrobial resistance could force up to 24 million people into extreme poverty. And 7% of the world's GDP would be lost due to antimicrobial resistance. So what do you mean by antimicrobial resistance? Unresponsiveness of a microorganism to an antimicrobial agent is termed as antimicrobial resistance. So this resistance can be passed on from person to person or from bacteria to bacteria. Your microorganisms are highly adaptable molecules, unlike you and I. They follow the Darwinian principle of selection, and they develop some stringent mechanisms or methods to circumvent the lethal effects of antimicrobial agents, and the process of evolution is going on. The antimicrobial resistance can be natural, intrinsic, or innate, or it can be acquired. So what do you mean by natural or intrinsic resistance? This resistance is due to the genetic makeup, the structure, or the physiological state of the microorganism. This can be due to a lack of target. Say for example, mycoplasma. Mycoplasma does not have a cell wall. So a betalactam, which is a cell wall synthesis inhibitor, has no role to play in mycoplasma. Similarly, your aminoglycosides. Aminoglycosides needs an oxygen-dependent mechanism to enter into the bacteria. So, in anaerobic organisms, aminoglycosides are ineffective. And Klebsiella. Klebsiella are naturally resistant to ampicillin or cephalosporin because they produce beta-lactamase enzyme which destroy the structure of ampicillin. But the natural or intrinsic resistance do not have much of clinical significance because these organisms were never sensitive to these drugs. Now coming on to acquired resistance. Acquired resistance is a major concern for you and I because the organism which was previously sensitive to a drug now becomes resistant to it. So the previously sensitive organism now gains the resistant genes and become resistant to the drug. This is mainly because of the widespread or irrational use of antimicrobial agents. The resistance can be spread by mutations or by horizontal gene transfer. And because of this, the bacteria alters its biochemical mechanisms so that it becomes resistant to the drug. So what do you mean by mutation? So in any population of sensitive microorganism, you would have a group of organisms which are resistant and which would require a higher dose of antimicrobial agent. In this case, I have denoted it as red. So with continued exposure to antimicrobial agents, what happens is there is killing of the sensitive organism leading on to proliferation of resistant organism. Now you can see you have a population of resistant microorganism. The transfer of mutation is from mother to daughter. This is a vertical transfer. Example for this is methicillin-resistant Staph aureus. This type of mutation or spread of resistance is usually slow and low grade. But you are more worried about horizontal gene transfer. One of the methods for horizontal gene transfer, and the most common one, is conjugation. Conjugation is bacteria's own version of sex. Bacterium 1, which is resistant, attaches to bacterium 2 via sex pilus. And this process, it transfers the resistant gene to bacterium 2. Now bacterium 2 also becomes resistant. The resistant gene can be extrachromosomal plasmids or chromosomal DNA. The other method is transduction. Bacteria has our own version of viral flu. They can also get infected with viruses. Viruses that infect bacteria are called as bacteriophages. So while infecting a bacterium which is resistant, these bacteriophages can take up few resistant genes and can transfer on to a new bacterium which is initially sensitive. So now the new bacteria also becomes resistant. The last method is called as transformation. This is a very rare phenomenon. So what happens is when a resistant bacterium dies, the DNA material leaks out, and this leaked out DNA and the resistant gene can be taken up by a sensitive microorganism, and now the new organism develops resistance. So this type of horizontal gene transfer is more rapid and the level of resistance is high. Usually you get multi-drug resistances in this way. The importance is that while vertical transfer occurred between mother to daughter, horizontal gene transfer can occur between any class of bacterium. Even different classes of bacteria can share the resistant genes. One of the examples is, transfer of vancomycin resistance from Enterococcus to Staphylococcus. So what are the biochemical alterations that occur due to these resistant genes? One of them is prevention of drug accumulation or entry. So your drug, which could previously enter into the bacterium, is now not able to enter the bacterium and thus becoming ineffective. One of the example is aminoglycosides. Aminoglycosides or tetracyclines, they need porins to enter into the bacterium. And if suppose there is some mutation in the porins channels, these antibacterials cannot enter and thus they are rendered ineffective. Modification of the target site. Everyone knows penicillin binds to penicillin binding protein and thus inhibits cell wall synthesis. If suppose the penicillin binding site is altered and it loses its affinity to penicillins, penicillin would naturally become resistant. This is one of the methods of becoming resistant, modification of the target sites. And if suppose your drug has entered into the bacterium, whatever drug has entered is pumped out via drug efflux. This is a common mechanism of tetracycline resistance. Then there are drug inactivating enzymes. The classical example is betalactamase. Betalactamase would disrupt the structure of beta-lactam and thus making beta-lactam antibiotics ineffective. The use of alternative metabolic pathways. All of us know that bacteria synthesizes its own folic acid. So it uses PABA and stearoic acid to synthesize folic acid with the help of folic acid synthase enzyme. But when you give sulfonamides, what happens is it would inhibit the folic acid synthesis and thus would interrupt the metabolic pathway, thereby killing the bacteria. But if suppose the bacteria develops sulfonamide resistance, what it does is it starts using preformed folic acid. It stops synthesizing its own folic acid, or it would increase the levels of para-aminobenzoic acid, thereby circumventing the inhibition of folic acid synthase. Now biofilms, because of the widespread use of medical implants, people who have endocarditis or scars or cystic fibrosis, they have this biofilm. Some of the organisms produce these biofilms, and what happens is your antibiotics cannot penetrate these biofilms, and your organisms remain dormant inside the biofilms, and they multiply as and when they have congenial atmosphere. So this can also render antibiotic resistant to the organism. Now other thing is quorum sensing. Quorum sensing is bacteria's own social networking. So different groups of bacteria communicate with each other and they pass on the informations about drug resistance. So these were the molecular mechanisms of drug resistance. Now let's try to understand our role in this menace of antimicrobial resistance. So one of the most important reason is irrational use, misuse or abuse of antibiotics. Antibiotics are, in our country especially, it's very easily available. It's even available over the counter. And nowadays with the advent of online pharmacy, the accessibility has increased even more. Sometimes wrong drug, wrong dose, and it is prescribed for a wrong duration of period, because of which this can aggravate the problem of antimicrobial resistance. And even after prescribing the right drug, the right dose, the right duration, as a patient you might not continue the course of the treatment, because once you start feeling better you'll think, what is the need of antibiotics now I can stop the drug. So that is another reason for antibacterial resistance. And moreover, in our country, where the regulations are not strict, we have a lot of counterfeit, spurious or substandard medicines that are available that even more aggravates the problem of antimicrobial resistance. Now the other thing is use of antibiotics in farming and in poultry or animal industry. It is believed that in USA, according to statistics, almost 80% of the antibiotics that are sold are used in animals or in agriculture. These animals, with continued exposure of antimicrobial agents, they become drug resistant. And they pass on this drug resistant bacteria in their excreta. And this excreta could damage the water bodies, the food that we eat, because the excreta might be used as manure or fertilizers, and that can contaminate the food that we eat, and the very air that we breathe is contaminated with drug resistance. Overpopulation. Overpopulation is a major concern for spread of antimicrobial resistance. Moreover, you have increased international travel these days, aggravating or adding on to the problem of drug resistance. Poor sewage, sanitization and poor hygiene is another reason for drug resistance. And use of antimicrobials in personal care products, like even some of the toothpaste has antimicrobial agents. And usually this is in substandard doses that would aggravate the problem of drug resistance. So how can we tackle this problem of antimicrobial resistance? So this was the theme of WHO in 2011. No action today, no cure tomorrow. So antibiotics is one class of drug where the use in one person can affect the effectiveness in some other person. So if a person has never taken an antibiotic, there is no guarantee that once he gets an infection and he takes an antibiotics, that antibiotic would be effective, because somebody else would be taking a lot of antibiotics and he would have got a drug resistant bacterial infections. So the actions that we take against antimicrobial resistance should be in a global perspective. So you need actions at the international level, national level, community level, at the hospital level, the individual healthcare practitioner level and the patient level. So at the international level, you need increased collaboration between various governments, non-governmental organizations, non-profit organizations like WHO. You should have strong networks for surveillance of antimicrobial use and antimicrobial resistance. Control of counterfeit, substandard antimicrobials, incentives for research and development of new drugs and vaccines, and programs to contain antimicrobial resistance. In India, you have a National Action Plan devised in 2017 to contain antimicrobial resistance, which is a 5-year plan. The main intention of this program is to monitor impact of antimicrobial resistance and to provide intersectoral coordination. Formulation of an antimicrobial resistance policy, making prescription-only availability of antimicrobials. They have also intention to make it legally binding for the drug manufacturers to give the data of drug distribution to the government as and when required. Incentives for rational use of antimicrobial agents and devising and formulating national standard treatment guidelines. Just like you have treatment guidelines for tuberculosis, you need to have treatment guidelines for other common infectious diseases. Enhancing coverage of immunization and regulating the use of antibiotics in agriculture or poultry. At the community level, you should have strong infection prevention strategies, improved vaccination coverage, ensuring healthcare for all, proper sanitation and waste disposal, and education programs for both the patients as well as the healthcare providers. Healthcare practitioner, what he can do is he can comply with the standard treatment guidelines and avoid irrational use of antibiotics. At the patient level, you have to stop taking self-medication of antibiotics and adhere to the treatment guidelines. Adhere to the treatment regimen. If you are prescribed the antibiotics for 5 days, continue the course and finish it. And of course, now it's a period of breaking the chain of infectivity. Once you are infected, isolate yourself and prevent the spread of infection. At the hospital level, you have the Antimicrobial Stewardship Program. So what do you mean by a stewardship program? Stewardship, the word itself means protection. So it is protection of antibiotics. It is a coordinated intervention designed to improve and measure the use of antimicrobial agents by promoting the right drug, the right duration, and the right route of administration. What are the goals of Antimicrobial Stewardship Program? Basically, it intends to optimize safe and appropriate use of antimicrobial agents to improve the clinical outcome and minimize adverse drug reactions, reduce antimicrobial resistance, reduce the healthcare cost, and reduce antibiotic-induced collateral damage. One of the examples is Clostridium difficile infection. So when you take antibiotics, the normal gut flora would also be killed, and this can predispose to Clostridium difficile infection. So who would you have in your stewardship team? It needs an infectious disease expert clinician, microbiologist, a clinical pharmacologist, epidemiologist, and a technician for technical support. The main elements of Antimicrobial Stewardship Program is prospective audit with feedback intervention. Here the audit is not done by the provider. That means if I am prescribing an antimicrobial agent, I am not the one who is going to audit my prescription. It is done by the stewardship team, which includes an infectious disease expert. And they would look into the rationale of giving the antibiotics, whether it is required or not, whether the dose is correct, whether the route is correct, or whether the duration of therapy is correct, and they would give appropriate feedback to the provider. And this would require, immense resource and expertise at every level. So usually this is reserved for, like soft tissue infections, urinary tract infections, and if you have more resource available, you can extend it to other complicated bacterial infections also. But this is something that is not, appreciated by the clinicians, might not be appreciated by the clinicians, because they would lose their autonomy, and they would feel that somebody else is trying to poke into my area of expertise. But everybody needs to understand that we are doing all this for a global good. Nobody is trying to demean you or rob you of your autonomy. It is just to prevent antimicrobial resistance, just to give you appropriate feedbacks. Now, other way is formulary restriction or pre-authorization. Some of the drugs are kept as reserve, and you need prior permission to prescribe those drugs. So this is one of the methods by which you can protect your reserve group of drugs that is kept reserved for multi-drug resistant organism. But the problems with this is it can delay the treatment process. Now the other supplemental elements of antimicrobial stewardship program includes education of both patients as well as the healthcare providers. This can be done via distributing pamphlets. As and when new treatment guidelines come up, you can also have CME. Now you can have a facility specific treatment guidelines based on the local antibiogram. So this standard treatment guidelines can be there for the common infectious disease based on the sensitivity pattern in your institute. So this is the WHO AWARE classification database. They have almost included 180 antibiotics. So some of them are included in the access group. The ones in the access group are, they have low chance of developing resistance. Then you have in the watch group as well as reserve group. The drugs which are kept in the reserve group are to be protected for the use only for multi-drug resistant organisms. Now there is something called as antibiotic cycling. What do you mean by antibiotic cycling? This is scheduled removal of specific class of antimicrobial to prevent or reverse the development of resistance. There are not much evidence to support this. But one of the things that supports antimicrobial cycling is that when sulfonamides were discovered, they were used left and right for bacterial infections. And soon, many organisms developed resistance to sulfonamides. But as you know, sulfonamides are one drugs which are notorious to cause serious hypersensitivity reactions, even Stevens-Johnson syndrome. So doctors stopped using sulfonamides for a period of time when safer antibiotic, came into market, when they had safer alternatives. So once they stopped using sulfonamides, what has happened now is organisms which were initially resistant to sulfonamides have started regaining their sensitivity. So this is one of the evidence that supports antibacterial cycling. The other thing is that you can have an antibiotic order form. So this is an antimicrobial order form. So these order forms are to be used except in life-threatening condition. So you have to, write what is the reason for prescribing the antibiotic, whether it's for prophylactic purpose or therapeutic purpose. You have to mention the route, the dose, and the duration of therapy, history of any drug allergy, or history of any renal impairment or hepatic function impairment. And you have automatic stops, especially for surgical prophylaxis. So it stops after 48 hours. Even if you have not given a stop order, it would automatically stop. So the stewardship team can look into this antimicrobial form and look whether the antibiotic is used at the right dose, the right duration, the right route, and whether it is needed or not. Now the other thing is to de-escalate or streamlining. So when you start on an antibiotic, usually you go for a broad spectrum, or empirical therapy is usually a broad spectrum antibiotic. Once you get your culture and sensitivity report, you should think about giving a more targeted narrow spectrum antibiotic. So you need to have a review of antibiotics 48 hours after prescription. You need to see whether the patient is responding. If the patient is responding, once your culture and sensitivity report has come, you need to think about giving a more narrow spectrum antibiotic. And once you switch on to a narrow spectrum antibiotic, again you have to ensure that the right dose, the right duration, and the right route has been prescribed. If the patient has not responded to the empirical therapy, definitely you need to change the antibiotic. And in every situation, you need to think about de-escalation or streamlining of antibiotics. The other thing is switching over from parenteral to oral therapy. That is more convenient to the patient, and that would, decrease a lot of adverse effects like thrombophlebitis. Now, apart from everything, all these things, you also need some technical support. Information technology, the role of informational technology in antimicrobial stewardship program. You can have expert computer clinical decision support system. So your standard treatment guidelines keep on changing based on the local antibiogram and the sensitivity patterns. So your computer clinical decision support system can keep you updated. So in that way, it can help the clinicians in decision making. The other thing that is important is computerized physician order entry and electronic medical records. So this is something that is going to revolutionize our, medical record system, so that everything is available at a fingertip. So you can have the surveillance becomes, in that way the surveillance becomes very easy. You can have the proportion of antimicrobial that has been prescribed, proportion of reserve group antimicrobials that have been prescribed, number of antibiotics, the doses that has been prescribed for the duration of therapy. Everything is available, every information is available. And also you can have availability of the sensitivity pattern. All these things are available at a fingertip. And if suppose somebody is having any drug allergy, so that is also alerted. If suppose you prescribe the drug which is the patient is allergic to, you get an alert. And if suppose you are prescribing some things which has drugs which are having drug interactions, again you would be alerted. So this is something that is going to revolutionize our field, and something that is very important, and we need to implement as early as possible. Now, the role of microbiology laboratory. So the most important thing for microbiology laboratory is to give a diagnosis based on the culture and sensitivity report. So that is the most important thing. The other thing that they need to do is they should ensure proper collection of the samples, and giving the diagnosis as early as possible. But nowadays you have molecular diagnostics. Say for example you had this mycobacterial tuberculosis infection. The culture of it would take a long time. But nowadays, with the advent of molecular diagnosis, it has become very easy to diagnose TB infection, and also even to look for which drug which are the drugs which are sensitive, which are the drugs that would act on this TB infection. So that's another thing that is adding on, that can be taken up for other infections as well. And the other thing that the microbiologists can do is they can restrict giving sensitivity of reserve drugs. They need not mention the drug, this organism is sensitive to colistin. If suppose some lower antibacterial is, the organism is sensitive to some lower antibiotics, they need to report only that. They can keep colistin sensitivity within, they can withhold it. And how can you measure the outcomes of antimicrobial stewardship program? Basically, what you can do is you get the prescribing pattern of antibacterials, compared to other drugs that are being prescribed. You can get the dose, you can compare it with the defined daily dose that is given by the WHO, and you can have the proportion of reserve group antibiotics that are being prescribed, and this would give, and the proportion of antimicrobial resistance that has been noted, and the proportion of mortality due to infectious disease. All this would give you a fair idea about how your program is going about. So all these programs and policies are very good at the paper, but at the end of the day, in our country how difficult it is to implement these programs. So at the end of the day, you need newer antimicrobials to counter this growing resistant bacterial infections. So are there any new antibacterials in the pipeline? Definitely yes. So you have drugs like fidaxomicin, you have drugs like radisolid, taurizolid, which are linezolid analogs. You have daptomycin, you have ketolites like solithromycin. All these drugs are designed to treat various resistant bacterial infections. Then you have a newer drug like cefiderocol. Cefiderocol is a cephalosporin with a siderophore molecule, and this drug is believed to be sensitive to carbapenem resistant organism. Especially it is designed to treat complicated urinary tract infections. Then you have newer combinations with beta-lactamase inhibitors like vaborbactam. You have meropenem vaborbactam, astriana mevibactam, ceftolozane tazobactam. All these are reserved drugs. And there is one drug you can see there is zoliflodacin. Zoliflodacin is interestingly it is funded by WHO. It is a topoisomerase 2 inhibitor. So these are some of the new antibacterials that are in the pipeline. Some of them have already been approved. And what are the future targets? Future targets are novel antimicrobials that can be derived from the nature, especially the herbal or plant products, and antimicrobial peptides from vertebrates, invertebrates, and other microorganisms, and targeted delivery like liposomal delivery or delivery through nanoparticles. Quorum sensing inhibitors like furanones, garlic extract, and modifying the already available antimicrobials to make it even more acute and better against infectious diseases. And drug repurposing. See, some of the antidepressant agents are being looked upon for their antibacterial activities, and this would save a lot of time because these drugs has been used for a lot of period. Okay, so the safety data can be ignored. You need just to look on the efficacy data. Then developing new vaccines, looking for biologics and phage therapy. These are some of the future targets that is being worked upon. So thank you very much. So start today and save your tomorrow. Please do subscribe to Vantage Pharmacology if you haven't already. Thank you for your listening.